Hello, everyone. I'm Jeff Staab. I'm a professor of psychiatry and director of the Consultation-Liaison Psychiatry Fellowship at Mayo Clinic in Rochester, Minnesota. I'd like to talk to you today about getting in the right mindset for doing consultations in patients suspected of having functional disorders. These are illnesses oftentimes called medically unexplained symptoms by our medical surgical colleagues, or conversion disorder, those kinds of problems. In the hospital, we're often called at the end of a pretty extensive medical surgical evaluation to see patients who are said to have nothing that's causing their symptoms. Similarly, in an outpatient setting, we might see them at the end of an extensive workup by medical or surgical specialists. Now, one of the problems with this is that certainly my generation and many others have been trained to think about this as dichotomously, as either a person has a medical explanation, surgical explanation for their problems, or doesn't, and if they don't, it's automatically psychiatric. That's a trap, and it's a trap that you'll never get out of if you fall into. And it's a trap because we can never be 100% certain that every single medical condition has been worked up, and it's actually not practical to do that. Nor do we know everything. Medicine changes. Things that were once thought to be functional are now known to be structural, metabolic in causes. So to avoid falling into that trap, it's better to think of this, the mindset that I bring and that our team brings is to think of what are the structural problems that our colleagues have identified, metabolic causes. What do we see from a psychiatric standpoint? And what shifts in behavior, shifts in functioning might the patients be demonstrating? And that's important because even in patients who do have identifiable structural metabolic problems, it doesn't necessarily explain all of their morbidity. So a patient who had a heart attack 2 years ago, but has been frightened to push himself for fear of having another heart attack is likely not to be functioning very well. But the cardiologist may say, look, his heart's fine, he should be able to do more. Or a young woman with orthostatic tachycardia, POTS. Lays low, gets deconditioned, exacerbates her POTS because of her behaviors. So thinking in terms of sitting down with your medical surgical colleagues saying, what's here structural and metabolically? If there are things here, are these things still active, or are they something from the past? And how much of what they've identified can explain the patient's full sets of symptoms and functional impairments? Then move on to the psychiatric part that we're familiar with. Looking for the kinds of things that we would want to know about. How much anxiety is there? Any evidence of an anxiety disorder, depressive disorder, other problems, developmentally, challenges in the person's lifetime currently, support systems and how well they're integrated in, or are they sources of conflict? Those things are right in our wheelhouse and may or may not be present in someone who has an unexplained medical presentation or an enigmatic medical presentation. And then we have to become more familiar with the functional disorders that our medical surgical colleagues have identified within their own specialties. We're pretty familiar with functional GI disorders, fibromyalgia, but other areas of medicine are really stepping up and beginning to define some of their own. Interstitial cystitis, now called pelvic bladder syndrome, and others. And so knowing where our medical surgical colleagues are coming from in terms of their look at these functional syndromes is helpful too. The last part of this is that identifying a structural problem says nothing about the presence or absence of psychological or functional comorbidity because they can overlap. The absence of a structural problem doesn't automatically mean that there's functional or psychiatric difficulties because there's sometimes we don't know. And if we truly don't know, it's better to say that we don't know and help the patient and family understand that than to pigeonhole a patient into a category of psychiatric or functional pathology that really doesn't fit. And that last part's a little tricky because patients will feel abandoned if everybody points their fingers in another direction and says, no, it's our problem, it's their problem, it's not our problem, it's their problem. And the way that we've found to handle that is to tell patients about what the uncertainty is. Patients know that we don't know everything, and if you sit down and have a thoughtful conversation with them and their family or significant other and say, here's what we think could be going on, this is what we don't know, and then develop a plan for following up and sequentially reevaluating them. We tell patients time is a great diagnostic test. It's a frustrating one because it takes time, obviously, but it is a useful one. And then let them know what it is that you're looking for. Help them keep track of the kinds of symptoms and problems that might one day lead to a better diagnostic impression. And in the meantime, using our psychological skills to help them improve their functioning and improve their engagement in worthwhile and joyful activities is a way to keep them on board and keep them going. So in summary then, leaving the 20th century dichotomous trap behind. It's not medically explained or medically unexplained, and if it's unexplained, it's automatically ours. But rather, sitting down with your medical surgical colleagues, what structural metabolic problems are there? How much of the structural metabolic disease that's identified explains the patient's morbidity? What do we see? What do we rule in from a psychiatric standpoint in terms of active psychiatric illnesses, past adversity, current social circumstances? And then what of the defined functional disorders or shifts in functioning and behavior can we see that may not be psychopathology per se, but aberrant illness-related behaviors that we can help with? And in those patients where we're really stuck, banding together with our medical surgical colleagues to follow over time and reevaluate. Thank you very much for your time.